As anesthesiologists, we are determined to provide the best possible care for patients that have to undergo a surgery or diagnostic procedures. At Columbia University, we also believe in discovering new methods to provide better care during this period. And we believe in teaching the new generation of perioperative physicians, as well as be leaders in the institution, in our field, and in society as a whole. As anesthesiologists, we are responsible for the patient throughout the entire phase of surgery. At the end of the procedure, we continue our treatment to further stabilize the patient and provide pain medication. Some of us do that in the post-anesthesia care unit, and others do that in the intensive care unit, depending on how stable the patients are.
Our ICU division takes care of patients in 3 intensive care units composed of 47 beds. Our expertise really lies in the resuscitation of the critically ill patient, the most vulnerable of surgical patients, and in the management of complex and evolving disease processes such as sepsis and acute lung injury. We've replaced listening with the stethoscope to looking with an ultrasound machine to try to determine lung and heart function. We believe that asking specific goal-directed questions at the bedside, such as, is this heart functioning, or is there water in the lung, has transformed our healthcare delivery model.
At the pain medicine group here at Columbia University, we treat a gamut of pain conditions. This ranges from acute pain to chronic non-malignant pain to cancer pain states in both the adult and pediatric population, and we do this in both the hospital setting and in an inpatient setting. We really believe in giving a targeted, individualized approach to each patient, really focusing on opioid-sparing mechanisms of pain control. But we always blend these therapies with cognitive behavioral therapy, psychotherapy, physical therapy, acupuncture. This allows us to optimize the best care that we can provide to the patient.
We at Columbia University see a great potential to develop new and better methods to provide medicine during the perioperative period.
Basic science plays an important role in our department in many ways. It enables us to significantly contribute to patient care by investigating new treatments and discovering new mechanisms of drugs that we use in the perioperative period for our patients. It also gives our residents and fellows a unique educational opportunity. Those residents that are committed to a career in academics are supported with mentoring and funds that they need to develop as a successful physician scientist. We realize it's very important to foster the next generation of physician scientists in Columbia, and what this program enables us to do is give them the time, funding, and mentorship needed to become successful.
Columbia is one of very few academic medical centers that has an affiliated school of public health. And our department in particular has forged strong ties to the Department of Epidemiology, which has really allowed us to push our science forward. It allows for many members of our department to go on to receive rigorous, high-quality training in clinical research, as well as fostering collaborations between our researchers and researchers within Mailman. I feel very lucky to be in a place like this that really supports clinician scientists and views me as a valued member of the department.
We believe that our trainees should benefit from the most advanced training methods, and we include simulation techniques, we include electronic media, and we also expose them to the state-of-the-art tools.
Our vision for the training program is to create an environment where questioning, interaction, and creativity form the core of the learner's experience. We innovate by creating the time and space that let our trainees become the people they want to become. We have an accelerated clinical time frame so that even in the first year, our residents are doing pediatric anesthesia, obstetrical anesthesia, and even transplant anesthesia. We measure our trainees' progress not just by what they know, but by how they think and how they approach problems.
The residency program at Columbia really tries to foster your independence early on in residency. And by your last year of training, you take overnight call as the team captain. So taking on this level of responsibility as a resident really allows you to more confidently transition to being an attending and knowing that you have the skills and the knowledge to be an excellent anesthesiologist no matter where you go.
The surgeons at Columbia do cases that aren't offered elsewhere, and we get to do the anesthesia for those procedures. For example, on your cardiac rotation, you might take care of a patient with end-stage heart failure who's going to have an LVAD placed, and then a few months later, you might take that same patient back to the OR for their long-awaited heart transplant.
In the spirit of Columbia's history of innovation, our educational focus is on trying to make our programs interactive, intensive, innovative, and inspiring. Our goal is to focus on trainee-oriented strategies such as problem-based learning. For example, we use the flipped classroom model to teach Journal Club once a week.
The ultimate goal of the training program is to produce not just clinicians that are competent, but to really produce the thought leaders of tomorrow.
Anesthesiologists are system thinkers and are process-oriented. We see them as natural leaders in institutions and in the healthcare system as such. Our key goal is excellence. We thrive for excellence every day in patient care, discovery, teaching, and leadership, all 4 areas that unite the Columbia and New York Presbyterian Hospital family.